Tokyo Live, Endoscopy go on.
Hello, everybody. Welcome to this session on the diagnosis and treatment of Barrett's esophagus. We have today here two world experts in the field of endoluminal treatment of Barrett's esophagus. So my name is Raf Bischops. I work at the University Hospital in Leuven. And it's my pleasure to introduce the first speaker, who actually doesn't need much introduction. It's Professor Bergman of the Academic Center in Amsterdam. He's head of the endoscopy unit. And as you know, he's also associated editor of gastroenterology for the endoscopy in motion section. So please, Jack, we are looking forward to hear a talk on EMR and ablation techniques in Barrett's esophagus.
Thank you, Ralph, for this kind introduction. And good day to you in whatever time zone you are attending this great live, or at least virtual live endoscopy session from Tokyo. I'm happy to speak to you about endoscopic management of early Barrett's neoplasia. Here are my disclosures. So this is where we were, at least in my country 10 years ago, if it came up to managing early Barrett's neoplasia. If you would have low-grade or high-grade dysplasia, endoscopic therapy would only be allowed as part of clinical trials, and any diagnosis of cancer, no matter early or more advanced, would deem you eligible for esophagectomy, but surely not for endoscopic treatment. And this is where we are now after an organ-preserving revolution over the last 2 decades. We are now treating high-grade dysplasia and mucosal cancers with endoscopy as the first choice. For patients with low-grade dysplasia, provided that the diagnosis is confirmed and reproduced, we now apply ablation therapy. And even for some submucosal cancers, esophageal preservation is a realistic goal. The approach we're using is a 2-step approach in which we first resect any visible lesion, no matter how subtle, with endoscopic resection, and only then proceed with ablation only after the resection specimen has shown us what the worst part of the neoplasia in that Barrett segment is. This is generally done in 3 monthly procedures up until the whole Barrett segment is then converted into squamous mucosa, after which we enter follow-up. Now, it's important to realize that an endoscopic resection, if it's part at the start of the procedure, it's also allowed at the end of the procedure if at any time point ablation therapy fails and you need a escape endoscopic resection for complete removal of the Barrett's neoplasia. So here's an example of one of the earlier patients we treated in Amsterdam, patient with an 8-centimeter Barrett's. He has a mucosal cancer here and here and here, and then a largely flat type high-grade dysplasia in his remaining esophagus. So we treated him with endoscopic resection of these visible lesions first, and then followed up with ablation. We could not convert the whole Barrett segment. Here distally in this zone, there's residual Barrett's mucosa remaining, but then after a single endoscopic resection session, the whole Barrett segment is then converted for a complete conversion of Barrett's and neoplasia. And these images are now 10 years old. The resection technique we use in the West for this, in most patients, consists of the multi-band mucosectomy technique, in which we do not use any submucosal lifting, suck the lesion in the cap, release a rubber band, and then snare this. We've published the results of over 3,500 of these procedures coming from 15 centers all across the world. And what we see is that the target zone can be resected in virtually all patients at a very low complication rate. The Boston Scientific Company has come up with a device in which the bands have been moved backwards on the cap for a more better view and a slightly wider working channel. We've done a prospective study in 17 centers with this device. smaller number of patients, but in the end, the complication of the resection rate and the perforation rate were largely comparable with what we knew from the duet. ESD in Barrett's is logically an option. Western endoscopists are gradually gaining more and more experience in this field, and Helmut Messmann, as a follow-up on my lecture, will show you how he and his centers have achieved excellent results in this. It must be realized that Barrett generally is a higher level of ESD complexity, and that for most patients, EMR and RFA is just an easier and safer approach with a very low recurrence rate. Nevertheless, ESD is simply necessary to be able to remove bulky lesions like this. A camp-based technique simply will not be useful. You will never be able to resect a lesion like this. And for this, an unblocked resection with ESD is simply the only approach for a curative endoscopic treatment. And we are using this for bulky lesions with interluminal components like this, or patients that have lesions that are suspicious for submucosal invasion. And our ESD resection percentage of the patients we see for early neoplasia and Barrett's is now somewhere between 25 and 40%. The majority of cases, however, we use this approach, a simple endoscopic resection technique, and then followed up with RFA as the ablation technique of choice. Here are the results of a multi-center European study in which we treated in 13 leading centers in Europe the patients with high-grade dysplasia and early cancer with endoscopic resection and RFA. Very high success rate if it comes to eradicating the neoplasia and getting rid of the Barrett's. And then during follow-up, virtually in all of these patients in which you achieve complete removal of Barrett's, there is a persistent remission of neoplasia and of intestinal metaplasia in these patients. Now, what about low-grade dysplasia? In the past, it was said that these are further on the left side of the spectrum and therefore have less to gain and more to lose. And surely that you should not be treating these patients outside clinical trials. It all depends on how severe this diagnosis of low-grade dysplasia is. Who is making the diagnosis? This logical diagnosis of low-grade dysplasia is not that straightforward. And here are results of a panel revision study that we did, in which we had 146 patients that were said to have low-grade dysplasia by Dutch community-based pathologists, and then 2 expert pathologists reviewed all the slides and actually found that they were able to downstage 3/4 of them, not as low-grade dysplasia, but actually as non-dysplastic Barrett's esophagus. And then, since we had follow-up on these patients, we could actually see what happened with these downstage patients. And it was actually found out that their progression rate was not that of low-grade dysplasia, but really resembled that of non-dysplastic Barrett's, a very low progression rate per year. However, the 15% in which this community-based low-grade dysplasia diagnosis was confirmed, they had a much more ugly course, with almost half of them progressing to high-grade dysplasia or cancer at a 13% progression rate per year. So in summary, at least in my country and in most other Western countries, low-grade dysplasia in Barrett's is overdiagnosed because 3/4 of these patients have non-dysplastic Barrett's with a very low progression rate, but it's underestimated for the 15% that have true low-grade dysplasia confirmed by an expert pathologist, because these have a much more uglier course. Now, this led to a logical randomized control trial comparing ablation with surveillance. And we had 68 patients undergoing ablation and 68 patients undergoing surveillance. And actually, we had to stop this randomized trial early because the progression rate to high-grade dysplasia or cancer, as you can see in this Kaplan-Meier curve, in the surveillance arm was significantly higher than that of the ablation arm. And this is the endpoint only focusing on cancer, which was also statistically significant. Now, this study had a follow-up of about 3 years. We 2 years ago, we extended the follow-up. We did a follow-up study that added an additional 40 months to the follow-up of this randomized study. And there were no additional progressors in the ablation arm. Yet, despite the fact that 15 of the patients in the surveillance arm elected to have RFA based on the results of the randomized study, we still had 5 patients that were not ablated and progressed. So this is then the Kaplan-Meier curve of that extended follow-up, really showing a significant difference in favor of doing elective ablation in these patients with confirmed low-grade dysplasia. And that's now in most of the guidelines. If you have low-grade dysplasia, you send a biopsy out for expert review. And if that diagnosis is confirmed, and generally if it's reproduced at the second endoscopy, that patient really has such a high risk of progression to cancer. It really doesn't matter if this is low grade or high grade. Those patients are at risk and therefore are eligible for ablation therapy. Now, we have recently looked at our long-term results after RFA in the Dutch Barrett's expert registry. In my countries, all patients with early neoplasia and Barrett's are treated in one of the 9 Barrett expert centers. So there's not a single endoscopic resection, not a single ESD, or not a single RFA performed outside these centers. These all have endoscopists and pathologists that have been trained specifically for this purpose and adhere to a common treatment and follow-up protocol, meet each other usually every 3 months, and each has to have an adequate caseload to be part of this Barrett Expert Center registry. So we had about 1,200 patients that were treated with endoscopic resection and or RFA, and then got into what's called complete endoscopic remission of Barrett's, and then they entered follow-up. And the follow-up was significant. The median follow-up was 4 years with 4 endoscopies, but there was a substantial number of these patients that really had long-term follow-up. 370 patients more than 5 years, and over 100 patients with more than 8-year follow-up. And very few patients were lost to follow-up. And these are the results. If you look at recurrence rate per year, low-grade dysplasia or more, 0.8% per year, high-grade dysplasia or cancer, 0.6% per year, which is basically a recurrence rate of a non-dysplastic Barrett's surveillance population. And then if you actually take a look at what kind of recurrence do you then see after you've done a complete ablation of Barrett's, a quarter of our recurrences have very dubious clinical relevance. These had low-grade dysplasia in a normal appearing Z-line. If we follow them up, none of these progressed. And you can question what the clinical relevance of such a recurrence actually is. The majority of our recurrent patients actually had a visible lesion with high-grade dysplasia or cancer, or they had recurrent Barrett's, tongues or islands with low-grade dysplasia, and these all underwent curative endoscopic follow-up. So here's an example of such a patient really having an ugly lesion for which we would now surely do an ESD, treated with a piecemeal EMR at baseline, then followed up with RFA for a complete removal. And then a couple of years later at the contralateral side, there is an ugly recurrence that we then treat with endoscopic resection. And this is now 3 years after treatment of this recurrence. Not the most fancy and best case, but really this is one of our worst cases, and still endoscopic treatment managed to treat the patients probably permanently. So here's our worst cases. These are the 5 patients that then during follow-up presented with advanced cancer. That's 0.4% of the total cohort. 2 of them still treated with surgery and cured, yet 3 of them dying of metastasized disease. We've published all these ugly cases are published on the best academia website, so you can see how we ended up with these patients. And these are all patients that were actually out of protocol. These were ugly cases in which we were really concerned if endoscopic treatment was actually the best choice. yet either surgery was not possible or refused by the patients. So it's fair to say that although these patients had an adverse outcome, it's only a very, very small part of the cohort. And usually these patients show their ugly face already at baseline. So it's fair to say that endoscopic resection and RFA really are the approach to be used, and especially in expert hands and centralized care as we have in our country, really have excellent results. So any new trends in this field is a new ablation balloon. Actually, the original ablation balloons are not longer commercially available. So this self-expanding and self-deflating balloon is now used in all patients if you want to do RFA. We ran a randomized study comparing how you should be using this balloon. This is the standard approach. So you ablate, you take out the balloon, and then you clean the segment with a cap, and then you go back with the balloon for a second ablation. This was an alternative approach that we tested. Just put the balloon in there, ablate, have the balloon deflate, and then immediately ablate the same area, so no cleaning and a double ablation at the same level. And this was an even easier approach. Just do a single ablation with no cleaning for a very quick and hopefully effective treatment. Now, in this randomized study, we had to close this double hit no clean arm actually prematurely, because we had 21% had really a severe stenosis. And if you look at the images of some of these patients, these are really terrible stenosis. And this is something we were not used to having after balloon-based ablation at all. And it's probably because this balloon expands to a larger diameter than we were used to, and our conservative approach with the previous balloons is simply not feasible here. So this is an approach that you should not be using. Should you then be doing an ablation, clean and ablation, which is cumbersome, or can you suffice with a single ablation? Well, this is just more effective. So there's a larger conversion rate to squamous neoplasia if you stick to this double approach. And therefore, currently, we advise to use this ablate, clean, ablate approach in all patients. Is there any room for APC or combining APC with lifting and this hybrid approach, in which we, through the APC catheter, first push fluid into the submucosal space, increasing the distance between the mucosa and the deeper muscle layer, and then allowing you to do a more aggressive and therefore probably also more effective ablation? There's a multi-center European study that actually recently has been published and actually suggests that the results are pretty good, but we probably need more data on this. And then this is cryoballoon ablation. Through a balloon, a transducer is passed, and it actually freezes up, in this case, 90% of the circumference, and you can do a double hit. So for a 180 treatment, we now also have a 180 diffuser, and the company is working on a 360 degrees diffuser. Pentac is actually commercializing this. There is a study going on in the US and a multi-center study going on in Europe, led by Bas Weusle from Utrecht. Here's a patient from our combined studies. This is the pre-treatment zone that we targeted, and this is then how it looks after treatment, only a very small island in the original treatment zone. And it appears to be quite effective. And then this is probably one of the newest kits on the block. This is really a technique that's in its infancy. It envisions that you would pass through your endoscopic catheter that would unfold to umbrella-like shields that would shield off a compartment through which you would then apply steam for ablation. So this is really still in its infancy. We're currently at a stage that we're using focal devices. There's a new focal device that we will be testing in Amsterdam in the upcoming weeks. And this is then how it looks. If you would do a patient in our study, this will be an area that we will target for the ablation. This is how it would look after an ablation. And this is how it then looks if you come back after 6 weeks. The original ablation zone for this case, very effectively treated. And for some of the other zones where we use different settings and energy settings, slightly different. Now, in all fairness, hybrid APC and cryoballoon ablation and this steam ablation, much of the interest is simply because it's new. If you have something that's very effective and has been around for more than 10 years, it becomes a little bit boring and people lose actually interest, no matter how effective and how safe it is. And new kids on the block simply attract some attention. From my perspective, hybrid APC may be something that works, but in my hands, it's simply too cumbersome and it's very much dependent on my endoscopic skills and my endoscopic assessment. And I really think it's inferior to RFA. Cryoballoon is new. There's few outcome studies. It may have some theoretical advantages, mainly if it comes to reducing stenosis, which we actually don't see in any of these studies. And we're really at a stage where we're still looking at feasibility and dosing, and we have to await the results of the 2 multicenter cohort studies that have been initiated. And steam ablation, nice, but we're not any further than feasibility studies at this stage. So from my perspective, for most Barrett's patients with early neoplasia, multiband mucosectomy with RFA is very effective and safe for most of these patients. And if you want to learn more about how you should approach these, this is a nice website. It's free, in which most of the technology, not only RFA, but also cryoballoon ablation, and not only EMR, but also ESD, and also with a nice module for pathologists, is available for free and for some good teaching. Thank you very much for your attention, and I will gladly interact with Helmut after this lecture for some nice discussions led by Ralph.
Thank you very much, Professor Bergman, for this excellent presentation. And as you said, we come back with a joint discussion. So it's my pleasure now to introduce the second speaker, who actually also doesn't need any introduction. It's Professor Messmann from the University Clinic in Augsburg. He's the current president of the ESG, and he will address ESD in Barrett's esophagus as a treatment option. So please, Helmut.
So thank you for the nice introduction, Ralph, and thank you for the invitation to this wonderful, even virtual meeting from Professor Inoue. It's a pleasure to be part of this meeting. And as you may know, Ralph is now our General Secretary for ESGE, and I'm his president, and we work together, and we have our marriage in April, and we work now together, hopefully very successful in the next couple of years. So after this wonderful lecture from Jacques Bergman on Barrett's neoplasia, I have this more or less provocative title, Pro-ESD. And after his presentation, I think we have to discuss, is there really a need for ESD in patients with Barrett's neoplasia? So I would like to start with a case. It's a 70-year-old patient, and he had an ulcerated bulky lesion in the short segment Barrett's esophagus. And the histology confirmed cancer, and the EOS staging, was more or less suspicious for submucosal invasion. So we recommended surgery, but the patient refused. And the next point is how should we approach in these patients who don't want to have any operation because of comorbidity and age. And we decided to put him on PPI. And indeed, after 3 weeks, this ulceration disappeared. And then we were lucky to start indeed with an ESD procedure and could resect this bulky lesion. And finally, the histology confirmed a mucosal cancer, which was quite interesting. It was a well-differentiated cancer, and RC resection was possible. And this is the nice result after a couple of months. So that means sometimes before we treat, a correct diagnosis and staging for Barrett's is essential. And we always are discussing EMR or ESD. What is the benefit of ESD? Well, we know for ESD, we can achieve RC resection and have a precise histopathology. And this study shows the problem of correct diagnosing. We have in EMRs, piecemeal EMR, we have sometimes a situation of RX, which means I'm not sure whether we have resected the lesion in total, and we have some underdiagnosis, or sometimes the conclusion what to do with this patient, to recommend surgery, may be wrong. And this is an example that with ESD you have a precise diagnosis, and histology can really help you in the follow-up and in the correct diagnosis of the next steps. So as Jacques Bergman already mentioned, the Barrett neoplasia, if you don't have any neoplasia, there is no need for any treatment. Surveillance is recommended in the majority. However, if you have a neoplasia which is not visible, then ablation technique, and this has been shown nicely by Jacques Bergman, is recommended. In low-grade dysplasia, there is a trend to ablate this dysplasia, and it has been shown why. For sure, surveillance is still in some clinics performed. I'm talking now on visible Barrett neoplasia lesions, which can be resected endoscopically, and when we have to use EMR or ESD. And early Barrett cancer is totally different from squamous cell cancer. Squamous cell cancer is rare in Europe. It's luckily well demarcated using NBI, using Lugol staining. However, it's more aggressive. If you have a M3, it's still questionable whether this is curative. However, in Barrett cancer, even submucosal cancer up to 500 micrometer can be candidates for endoscopic resection. This is the German guidelines translated, and we recommend now endoscopic resection should be performed. 10 years ago, we had here can be performed, but now even our surgeons accept that endoscopic treatment is treatment of choice in early neoplasia. With special indication, mucosal cancer, well differentiated and non-ulcerated lesion. A complete resection should be achieved. This is for sure better if you have an en bloc resection. And indeed, endoscopic resection can be performed in submucosal cancer if the invasion depth is less than 500 micron. And the same recommendation comes from ESG guideline. A curative intent is necessary for visible lesion. And as Jacques Bergman mentioned, EMR should be preferred. This is still the treatment of choice. However, ESD can be considered in selected cases, which means larger lesions, larger than 50 millimeter, if you have a poor lifting for reasons whatever, and you have lesions suspicious for submucosal invasion. This is a milestone paper from Christian L. and Oliver Pech, and it has demonstrated in 1,000 mucosal cancer that EMR is very effective. This study did not mention the size of the lesion, but anyway, it demonstrates a high complete local remission of 96%. The problem of metachronous lesions is still here visible. However, in the long-term run, the data are excellent. But as mentioned, the size may be a matter, and it is not mentioned here. Another point which is discussed in the guidelines is the discrimination of mucosal and submucosal cancer. And we recently published a study where we had more than 230 white light images, which were analyzed by 5 international Barrett experts. They had to classify these images. It was not a video. This is a disadvantage. They had to classify, is it mucosal or submucosal cancer? And we trained AI is still something which is very new, but maybe help us in Barrett's as well. And this study also examined the place of AI in differentiating mucosal and submucosal cancer. And what we found is that the AI system, compared to the experts, had a sensitivity for endoscopists of 36% for the AI 77, and the specificity was higher in the endoscopist group and lower in the AI group. That means even experts have problems and can do better, but this is for experts sometimes, I don't think, not possible. However, with this small number of images, it was possible to train a system. And I think if you have more data and the videos, it is more robust a system like this to achieve better discrimination of mucosal and submucosal cancer. The one of the first largest series at that time comes from our center on submucosal dissection, larger lesions. And you see, depending on the Barrett's length, we achieved a block resection rate somewhere about 90% and our resection for cancer between 70 and 90%. Now, there is still one randomized trial coming from Horst Neuhaus groups, a small series of ESD and EMR group, and the lesions were also very small, 15 millimeter. The histology, you see, complete resection was significantly higher in the ESD group. However, after a short follow-up of 13 days, there was no difference in the complete remission of the initial resection. And as shown here, the mean number of pieces for sure was in the ESD group lower. However, this study was criticized for a number of reasons. The number were small lesions, mainly short Barrett esophagus, a very high number of perforation rate, which is maybe a problem due to the device that was used in this study, and the low R0 resection rate, and this short follow-up. Pradeep Bhandari and his group published a multi-center trial showing that you need about 30 cases to achieve an en-bloc resection rate of 90%. And meanwhile, this meta-analysis recently published on 11 studies, more than 500 patients, so on a larger lesion, that a block resection rate can be achieved in 93%, R0 resection in 75%, and a curative resection in 2/3. Perforation and bleeding is seems to be low. The stricture rate in ESD treated patients seems to be a problem. And the recurrence rate, as we can expect, is also very low. Now, these are the cases of this meta-analysis. All study centers have low numbers, as you see here. Only this study from Pradeep Bhandari with 3 centers had a bit more. The problem, as mentioned, was this randomized trial with the highest perforation rate, but I think it was because of the devices that were used. And the R0 resection is obviously associated with this device, because R0 resection means either you have problems in correct diagnosis, delineating the lesion, or problems with the device. But our block resection rate is always a criteria. How good are you performing ESD? And this is high in every center. Now, the meta-analysis from 2018 showed that if you look at this 500 patients, these are the data. And now recently, a couple of days ago, we achieved that our German registry has now been accepted for publication in gastroenterology. And in this registry, we had almost 300 Barrett cases. And these are the data. Again, our block is 96, R0 about 75, and curative 70%. The bleeding and perforation risk is low. Looking in this data, we looked at our study at our center, and the Augsburg group had 50% of this treated lesions came from our center. And as you can show, if you have a high volume, the R0 resection is significantly higher as in a low volume center. The curative resection rate is higher, and up to now, we use the hook knife. We have no perforations. Why is it? We started ESD ago since 2003. Meanwhile, we're performing 200 ESD per year and about 60 to 70 cases every year on Barrett's. So indeed a high number. And this is a registry we published. This were all organs, stomach and colon included. This is the number one is Augsburg. You see, this is a very high volume center, but there are also other centers in Germany which are high volume centers and perform more than 50 cases. Now, looking only at the Barrett cases in this registry, Augsburg compared to the remaining centers, you see the block resection rate was not significant, though the technique is feasible, is performed in every center well. However, R0 resection and curative resection seems to be in very high volume centers better. Now, this is an example of a lesion, a bulky lesion, which is as recommended in the guidelines, needs to be treated with ESD. This bulky lesion is, however, very soft. So we don't expect any deep submucosal infiltration. It's because just it's bulky and the cap resection does not allow huge pieces. So this is, I think, a nice indication for a resection, and we usually start with staining and acetic acid and indigo carmine, and this lesion now is well demarcated. And the next step is putting some markings on the lesion, then the injection, and then continuing by dissecting the lesion with shown here with the hook knife. And I go a bit forward to show you that this is very nicely done under control. However, as a disadvantage to ESD, it takes longer and the patients are intubated if we treat patients with ESD in the esophagus. However, we finally have a nice histopathology result, a zero resection in this case. And we also, as you see here, we leave a tongue of regular mucosa, and this is the specimen. Oops. This is another case which seems to be also interesting for ESD, a patient with varices because of liver cirrhosis, and there's a bulky lesion on a varice. So we treated a couple of those cases, and in this situation, as he had several bleeding episodes, we treated him with the tips before endoscopic resection. After the tips, and you see the scars of the ligation from previous bleedings, and you see reflux lesion. So it is quite difficult to perform an EMR here. And for safety reasons, we used again the hook knife. It was also a non-lifting lesion, and this lesion could also be very nicely demarcated first and then resected with this also using TXI. It's a new technique which shows you much better the vessels, which is probably helpful in some indications. And finally, with the so-called clip line technique, the lesion was completely resected. What also is very important in ESD, you see very nicely the vessels and can perform a prevention and a prophylactic treatment of vessels to avoid severe bleeding. And finally here, the clip line, which sometimes is helpful to improve the lifting and to continue the procedure. This is at the end of the procedure, the result. Now, and the final case, also a long segment Barrett with islands within this Barrett's esophagus, which obviously is always a sign that there was severe reflux, and within or close to these islands, neoplastic area, and as already mentioned, very difficult to delineate these lesions, and therefore endoscopic resection with ESD seems to be helpful. And here underwater and with a near focus, the delineation is better. And finally, we combine acetic acid, which is helpful to delineate. We have this nice whitening, and then we combine it with indigo carmine, and finally with TXI, you have a really a nice area visible where the margins are, and you can perform this huge ESD lesion to resect. And this is again the end result. Again, we leave a small regular mucosal tongue, which is necessary. Why is it necessary? This is the histopathology of this mucosal cancer. In some other cases, as Jacques mentioned, after ESD, it's always necessary if you have remaining islands left to continue with ablation technique. He mentioned the different ablation technique which are on the market. Circumferential Esd, is this the future? This was a patient with multifocal dysplasia. Biopsies were taken because he was anticoagulated, had severe bleeding, and we performed a circumferential ESD. After a couple of days, this was a a huge defect. And then with steroids and PPI, you get a nice reepithelialization. And meanwhile, we published our regime using prednisolone to avoid strictures, starting with 50 milligrams. Then at 2 weeks, a first control endoscopy. Then we decide, depending on the clinic situation and the endoscopic image, and continue or increase the prednisolone and have a second control after 2 months. And using this regimen in those patients who have not a circumferential ESD, in 90 cases or in 70 cases, only 5% develop a severe stricture. But if you have a complete circumferential resection, almost all patients have a stricture. And the final indication is for sure the pre-treated Barrett neoplasia. Here is an analysis, non-published so far, 245 cases. 10% were pre-treated. Here are the pre-treatment methods. And if you compare the naive Barrett neoplasia with the pre-treated, you see there is a lower R0 resection, but still ESD is possible in this situation. So let me summarize. This is almost mentioned. I go straight forward to ER, and ER is EMR or ESD, and the place for ESD, I think, is the size, is the suspicion for submucosal invasion, which is sometimes quite difficult, as mentioned. If you have a pre-treatment lesion or a non-lifting lesion, then I think the guidelines and also my personal experience is to recommend ESD. And now I close my presentation with an invitation next year to the ESG days in Prague, and we hope to welcome you also from your country. Thank you so much. And now I'm happy to discuss with you the treatment of Barrett's. Thank you.
Thank you very much, Helmut, for this excellent contribution. So it's actually nice to see that after sometimes in the past some heated discussions between EMR and ESD, that we seem to find a common ground now, Jack and Helmut, where this technique seems to fit in. I would like to discuss briefly 3 points with you in this discussion. It reflects on ESD itself, low-grade dysplasia, and the follow-up. So first with ESD, following up on your presentation, Helmut, you often mention the curative resection rate, that it is lower for ESD in comparison to EMR. But what exactly, I mean, because this kind of reflects negatively on the feature of ESD, but what should we consider as a curative resection if we do ESD? Can we extend our...
Yeah, well, the majority of studies just look at the result after ESD and does not combine with any ablation technique. So that was the first definition in those studies. And also always the discussion, if you have still a low-grade dysplasia at the margin, is this a curative resection? This is different in the studies. And the majority definition is that if you have a cancer or high-grade, it's curative. If it's not, it is R0 resection. If you have low-grade dysplasia at the margin, it is defined as a curative treatment for the cancer and for high-grade dysplasia. And that's the reason it's the curative resection rate is so low with 2/3. But that means you still need an ablation technique for sure.
So Jack, should we reverse this terminology when we do ESD? Should we review?
Yeah, I just don't think it's a fair outcome for ESD or for endoscopic resection if we say that high-grade dysplasia or low-grade dysplasia at the lateral resection margin is actually non-curative. It's for where we stand. It's really irrelevant. If we do a piecemeal EMR, we say to a pathologist, don't bother with the lateral resection margins because we don't even want to try to put the pieces together. The only thing I want to know is the vertical resection margin, is that free? How deep does it invade? And are there risk factors for lymph node metastasis, like a poorly differentiated cancer or lymphatic invasion? Generally, that's the idea is that ESD, since it provides a single specimen, allows to assess these parameters better, and it's logical to do so. But poorly differentiation, lymphatic invasion, the vertical resection margin assessment generally can be done on piecemeal EMR specimens just as well. But I think the outcome of, if you look at ESD outcomes, I would say that high-grade dysplasia at the lateral resection margin is not an adverse outcome and doesn't do credit to the quality of the ESD if you consider this to be non-curative.
I think, yeah, sorry. I think this was only this definition because in previous studies, the aim was to show how effective is ESD. Do we need additional treatment? And this is the reason why we just look at the outcome of ESD. And therefore, Ashak, you're right. We know that the low-grade dysplasia at the margin doesn't play a big clinical role. But it's just like surgery. Do you need, if you have a surgical resection of a colon cancer and remove all the lymph nodes, is adjuvant chemotherapy is necessary, or can you also do a quick and Japanese colleagues sometimes say quick and dirty resection, and then perform in every patient chemotherapy and look at the outcome after 5 years. And if both is fine, then you can say, well, both is effective. And then you have to look at quality of life. You have to look at cost and so on other parameters if there is no difference in the clinical outcome. Yeah.
So what you're actually saying is that a so-called, by definition, non-curative resection can in fact be curative for the patient, even if we have deeper submucosal invasion, right?
Well, one of the things we've encountered when we looked at the Dutch ESD results, that if you really select ESD only for lesions that have a high suspicion of submucosal cancers, that means in our cohort, there's over 50% of those patients really have submucosal cancers, that a significant number of these patients will have a R1 resection. And some of this actually is because we're resecting deeper invading lesions. But some of this also reflects what happens if a Western endoscopist tries to do an ESD. Sometimes you touch the deeper part of the resection specimen while you do your dissection, or you coagulate a blood vessel and your resection margin gets a coagulation damage that is then misinterpreted by the pathologist as an irradical resection. And you can see in Helmut's results that his results are significantly better than that of other German centers, whereas the other German centers still are recognized as being expert centers. And you and I know, Rob, that even if we are very good in doing ESD, sometimes at the end of the procedure, the orientation gets a little bit difficult. And sometimes you find that you actually have resected or dissected partially into the resection specimen and not into the deeper layers. Okay. So maintaining, especially if the lesion is bigger and it's semi-circumferential, it's inevitable that ESD, although a much more elegant and logical technique, will give more artifacts if it comes to vertical resection margin assessment, at least in the hands of Western endoscopists. And this is where we probably need a little bit more guidance, that we do not automatically interpret any R1 resection after ESD as an immediate indication to proceed for surgery, because some of these are artifacts and many of these patients are old and frail. And very, very often you will not encounter any cancer in the resection specimen or not any cancer if you continue these patients on the follow-up. So this is very cautious. Be careful in interpreting an R1 resection after ESD, especially if you're not done as many cases as Helmut's group has.
I mean, so far in our tumor board, if we have a R1 resection or RX resection, for sure our surgeons recommend additional surgery. Because we don't have data, long-term follow-up data to rely on this experience. You have to say, well, Usually, if you have our series section in the majority, it's safe, nothing will happen. So far, I think we don't have the data at the moment to even the long-term data to recommend it in guidelines. But I'm agreeing with you, Jacques. We had the same experience in the colon and the rectum, where in the initial phase we had a lot of RX or R1 resection because it was at a phase when we were very close dissecting to the lesion and so on. So also for some technical reasons, this is always a matter of debate. Yeah.
Yeah, just now, let's move to the other side of the spectrum, the low grade. So Helmut, you mentioned that, yeah, surveillance can be still an option. That's often done in Germany. If I look at the Dutch results, Jack, you have 27% of the patients in your registry that has been treated for low-grade dysplasia. So it seems to be like a done case in Holland. So taking the recent French study in consideration, maybe you want to comment on that. How do you select your patient? Do you ablate every confirmed low-grade dysplasia? Does need to be multifocal? Do you take the length of the Barrett's in consideration? So maybe Helmut first.
Well, just to avoid any misunderstanding, we also treat low-grade dysplasia. I don't perform surveillance, and the new guidelines which were updated right now in Germany, we have the term low-grade dysplasia should be treated and can be surveyed. So it's a clear now option going more to therapy and not to surveillance. Okay. But surveillance can be an option. I think the patient won't die of this. Yeah. Because we surveil them, and if you see there's a progress, you still have a situation where you can treat.
Exactly. So what's your view on that, Jack?
No, I think it's as Helmut is putting it right on the mark. There is no need to treat patients with low-grade dysplasia if you are 100% sure that you will do an adequate surveillance. That's the key element here. So in my country, where all these patients are followed up only in 9 centers, I vouch for the quality of surveillance. And I would say no low-grade dysplasia, even if it's confirmed and even if it's recurrent, actually needs ablation as long as this patient remains in the hands of these expert endoscopists. In all fairness, this is not reality in many other countries, especially in the US. The quality of surveillance for these patients is compromised. And then ablation maybe is just a safer approach than keeping these patients under endoscopic surveillance. I would not ablate an 80-year-old with a 12-centimeter Barrett's with low-grade dysplasia. I would for sure ablate a patient with low-grade dysplasia that's 50 years old and has 6-centimeter Barrett's. That patient has a life expectancy of 40 years. He will get a cancer. We can survey him and we will find the cancer at an early and endoscopically curable stage, but he is just waiting for trouble in his Barrett segment. But that's a minority of cases. And even high-grade dysplasia, flat high-grade dysplasia in an 80-year-old, after Helmut has resected the ugly cancer with ESD, that's actually what is curing the patient. And then the ablation is more prophylactic and not necessary in many, many of these patients. So as long as you can vouch for the quality of surveillance, ablation is simply an alternative. But the quality of surveillance is then very dependent on the quality of the endoscopist.
Okay, that's clear. So and finally, just a brief answer. I mean, I'm always a little bit puzzled. I mean, if somebody develops leukemia or lymphoma after 5 years, the oncologists say, okay, you're clear. You're done. You don't have to come back. No further surveillance. And we keep on following these patients year after year for 10 years, even in the Dutch registry now. So when should we stop doing this, Jack?
Well, the question probably does not pertain to the esophagus. It pertains to the competing risk that patient has for other disease. So a patient that still has maybe a 5% risk of developing a cancer probably will not die from that cancer. He will probably die with that cancer. So actually what we're doing now, we're actually modeling these factors into a decision tool. I think as endoscopists, we're doing way too many endoscopies. And sometimes even a patient with an early cancer, actually, in all fairness, does not need a treatment. He will die with his cancer, not from his cancer. So if that decision-making comes into play, then logically follow-up after a complete endoscopic remission really does not make any sense. So in the next 5 years, I think we will become much more liberal and say, okay, I'm not sure what will happen to your esophagus. But basically, please don't look at the esophagus anymore, because you will likely die from your cardiovascular risk or whatever other things you have, and stay out of the hospital to save cost and also to save loss of quality of life, because you worry about a disease that really bears no relevance for your further clinical history.
Last comment from you, Helmut, regarding this last issue.
Yeah, I totally agree with Jacques. I think first, we don't have this data on patients who had cancer. We know from patients who had Barrett's esophagus and developed no dysplasia that the risk for developing later on a dysplasia is very low. And similar to the colon, we do obviously too much of surveillance and endoscopy all in the upper GI. So I think there is a need to have more data. Maybe in the future, Jacques, AI can help us to find a solution which patients needs more aggressive, more intensive surveillance, and those who never will have a second cancer. At the moment, I think it's individual decision in my clinic, depending on age, on comorbidity, as Jacques said, and the majority of those patients are anxious, live in fear to have a second cancer and come back on a regular basis. But sometimes we also miss patients. No, they don't come back, and the surveillance is missed.
Okay. Well, thank you very much, gentlemen, for your excellent contributions, lectures, and also for the nice discussion. So I think this brings us to the end of this session. Thank you for listening in.
It was a pleasure. Thank you.